Welcome to Practical Guidance for Airway Management of the Coronavirus Patient, presented by the 4 national directors of the Difficult Airway course. I am pleased to introduce our host, Dr. Calvin Brown.
Great, thank you, Terry, and hello, everyone. Thank you for joining us this morning. If you have joined us for previous Airway World podcasts, so you know that we typically have a research update. And given the coronavirus pandemic, we thought it would be very topical to change our format a little bit and discuss what we feel as airway leads at our institutions and airway educators, what we think are practical guidelines for airway management in the coronavirus patient. My name is Calvin Brown. I am the Vice Chair of Network Development and an attending physician at Brigham and Women's Hospital, Associate Professor of Emergency Medicine at Harvard Medical School. And we are very fortunate to have with us several other panelists, so I just want to introduce them. The first is Jared Mosier. You may know Jared if you are in the critical care community. He is our course director for the critical care course, and you can see his other credentials there. He's Associate Fellowship Director for Critical Care Medicine, is the co-medical director for the adult ECMO program at the University of Arizona in Tucson, and he is a practicing emergency physician and critical care physician. Our second panelist is Darren Brody, who is here for general knowledge, but also has a specialty in pre-hospital medicine. He is a paramedic as well as an emergency physician. He is faculty for the Difficult Airway course emergency and is the course director for the Difficult Airway course EMS, is full professor in emergency medicine and anesthesiology at the University of New Mexico School of Medicine in Albuquerque. And then last but certainly not least is Adam Law, who is the course director for the Difficult Airway course anesthesia, full professor in anesthesiology, emergency medicine and surgery at Dalhousie University, and is an attending neuroanesthesiologist in Halifax, Nova Scotia. So we have a very good set of expert panelists that I think bring in a broad range of expert opinion from different environments. So this should be really a robust discussion. We need to show you our disclosures, so you can see them listed in the box below. I don't think I need to read them, but just for your information, and we're required to do so. This webinar has been approved for 1 AMA PRA Category 1 credit and 1 hour of CAPC advanced credit. Everyone in attendance will receive a certificate by email within 3 weeks. The objectives of this webinar are the following. At the conclusion, you should be able to, in addition to other things, describe the challenges of intubating patients with COVID-19. We are going to frame our discussion around 3 main principles of safe intubation practices, so you should understand those, and hopefully be able to pull some of those things away and apply some of these practice modifications to your own site. At the end, we also have a list of additional resources for additional reading should you want to explore more, so you should have those at your disposal, so you want to be able to identify those additional resources and use them as needed. So the agenda is as follows. We've already done the introduction. We're going to review what we feel are pragmatic recommendations for safe intubation practices. I want to say, though, as a disclaimer that, and I think everyone who's listening understands this, that these recommendations and current practices change very, very frequently. At our institution, it seems to be every hour. And so what we are going to share with you are things that seem reasonable and practical at this moment. A lot of the stuff that's out there has very little high-level evidence behind it, but a fair amount of face validity. So this is not meant to be a strict, rigid, this is the only way to do it type of presentation. We understand that people may have their own ideas about this, and we encourage you to share your thoughts, post questions, and we will get to those throughout the presentation and have a dedicated amount of time at the end to try to tackle as many questions as we can. So I know that you all know this, but just by way of background, we are going to discuss COVID-19. It is a novel respiratory virus in the coronavirus family. And the reason why it's an issue now is because it's a new strain that's not been introduced into human circulation, and so we do not have immunity. And because of that, although most people have very mild disease, there is certainly the potential for folks to have serious respiratory illnesses. And the current U.S. mortality based on actually pretty consistent numbers now is somewhere between 1 and 2%. There is no known cure, although there are certainly things that are being explored and I wouldn't say experimental options, but off-label use of certain medications like chloroquine and Zithromax to try to reduce viral load and shorten the duration of illness. Vaccines are something coming down the pipeline, but certainly is several months away. It is a pandemic, so it is worldwide. This is a representative heat map of places where coronavirus is currently active. And you can see the deep red that currently colors in the United States. And I don't think we need to go over that. Everyone knows that the cases are rising daily, as are deaths. So it's important for all of us. Everyone is going to get touched by this respiratory illness in your own practice. So what I'd like to do is start off by just framing how we're going to go over the discussion this morning. So we have, and this is not the only way to think about this, but what seems to make sense to us is to discuss this in the context of 3 overarching intubation principles. And the 3 principles are, number 1, intubate the patient safely with minimal aerosolization of viral droplets. Number 2 is to think about strategies that would maximize first attempt success. And we are always looking to maximize first attempt success, whether we're intubating a COVID patient or not. But there are some things that you might want to be more rigid about to ensure that intubation success happens quickly and is most likely to happen without the requirement for a second intubation attempt. And then the third, of course, is we want to limit contamination to healthcare providers as much as possible. And I think I already mentioned this, but this is information that is evolving. We are changing our practice based on new data and thoughts about this that seem to come out every day. But for the most part, recommendations, no matter who you look at or go to or lean on for this information, is based on fairly limited evidence. So this is an infographic that we put together now maybe 2 or 3 weeks ago. It was really a collaborative effort between me and Jared and Adam and a couple of other folks that we work with very closely, Justin Carlson and Mike Gibbs. And this is just, we're going to use this as a basic framework to facilitate our discussion. I think there are some practical items on here that you could look at and take home, but there's certainly more to this than what is listed on this infographic. So we're going to start by discussing minimizing aerosolization of virus. Of course, the intent there is to prevent spread. We're going to talk about things that we think would maximize first attempt success and thereby not only improve patient safety, but the safety of folks in the room. And then things that you can implement to limit contamination. And that's important because you really want to reduce your personnel exposure. Healthcare availability or healthcare provider availability is going to become a real issue. And in our institution, we already have 20% of our faculty who are out with symptoms of some sort. We don't know necessarily if they're all COVID positive, but this is going to be a real issue. So to the extent that you can reduce personnel cross-contamination, that is going to allow you to continue to have a deep bench of backups who can continue to work clinically until this pandemic is over. So let's start with our first overarching principle of airway management, which is reducing aerosolization. And I've just clipped a 1/3 of that infographic that you saw on the side. And then what's going to pop up on the right-hand side of the screen in a minute are some additional things and tips and pearls and controversies that have come up at our own institution as we've started to think about this much more deeply. So as we go down this list here, and the other panelists can jump in at any time, there are certain things that you want to try to abide by to minimize aerosolization of the virus. The first is, if you have a patient who comes in respiratory distress, how do you think about managing that patient in the context of other modalities that are available for managing respiratory distress, right? So if you have someone with a CHF exacerbation, acute pulmonary edema, or potentially an infectious cause of their dyspnea, there's lots of things at your disposal, from supplemental oxygen to BiPAP, high-flow nasal oxygen in some settings. And the general guidance around patients who you think might need oxygenation ventilation support is that early tracheal intubation is highly preferred over using these other modalities unless ventilators are not available, and we're going to talk about that later. Early tracheal intubation puts the patient on a ventilator that supports them but also keeps them on a closed system. And early tracheal intubation is important because if you wait until these patients get sicker, it is a much more hazardous and risky procedure. And we'll talk about what we are using at our institution for early intubation triggers, and I'm sure the panelists will share their own thoughts on this as well. Of course, you want to intubate in a negative pressure room when those rooms are available, understanding that they may not always be available. At one of our institutions, we have a 26-bed ED and one negative pressure room. So it's a real issue. You want to avoid nebulization of medications if possible. When thinking about respiratory medications, you want to try to deliver that by metered dose inhalers if you can. HEPA filters should be in line anytime a patient is breathing through a device or you're applying positive pressure, and we'll talk about that in more detail. Rapid sequence intubation, as opposed to awake techniques, should be the preferred method, and the reason is you do not want the patient breathing, coughing, responding to airway manipulation, because that will spread viral droplets. You want to avoid positive pressure ventilation, high flow oxygen if you can. Of course, you will do anything if it's clinically mandatory. And after the tube is placed, you want to think about things like immediate cuff inflation before you either check tube placement or attach to a ventilator or provide any type of positive pressure. And then after the tube is successfully placed, you really want to work hard, and this involves very close communication with your respiratory therapists about limiting ventilator disconnects to the extent that you can. If a ventilator disconnect or some ventilator maintenance needs to happen, this should be done whenever possible at the end of expiration, so that when you disconnect the patient, there's not all this potential energy, for lack of a better way to describe it, built up in the patient's chest that would continue to expel exhaust and viral particles if you disconnect the patient from the device. I have some other things that I'm going to show here in a minute that have come up at our institution, but I'm going to pause here for a minute and let the other panelists chime in and comment on any of these items before we move on. So why don't we start with Jared?
Yeah, I have a couple things. The first is that I know everyone kind of cringes when we think about intubating somebody who's on 6 liters of oxygen because we want to intubate them early. But if you, for some historical perspective, all of this pre-oxygenation with BiPAP, high flow stuff was born from H1N1 because of all of the patients that were rotting on BiPAP and died on induction for intubation with that disease. And so the longer, because we're saying don't use BiPAP and high flow for pre-oxygenation, the longer you wait after they start to exceed 6 liters of oxygen, the more dangerous that intubation becomes. That's point number one. Point number two is that one of the reasons you can't use BiPAP for either pre-oxygenation or treatment is number one, BiPAP has an incredibly high failure rate in hypoxemic respiratory failure. And number two, the BiPAP circuits exhaust into the room. So if you have to pre-oxygenate using positive pressure, you need to use a closed ventilator circuit with a bag valve mask. That's all I have.
Great. So I think, and I'm going to bump it over to the other panelists in a second, but I think this brings up a couple of things that we were going to discuss in more detail, and you touched on some of these. So the first bullet is what is an intubation trigger? And what does it mean to have an early tracheal intubation? And I think you touched on that. And at our institution, what they are using in the hospital, if we admit patients who are mildly symptomatic but then progress and get worse in the hospital, is they are using a 6 liter per minute oxygen flow requirement to keep the SAT between 90 and 92%. And if they have progressed to that point, that sends a trigger to the inpatient intubation team to put these folks on their radar because they are likely going to need an intubation in the near future. And like you said, what we know from prior experience is that the natural history is if they reach that point, they are likely to worsen and need it, and it's a riskier intubation later on. How about Adam or Darren? Darren, how about you? Anything to add?
I think one concern I have is that, and I think you addressed this a little bit in one of your bullet points on, is positive pressure ventilation absolutely contraindicated? And earlier you mentioned, clinically you do what you have to do, you try to avoid these things. I think there is some thought out there that folks can't do any form of positive pressure, that it absolutely must be avoided. And one of my concerns and one of the things that I've seen here in some of our early COVID intubations is if you get in a critical situation and then you're frantically trying to make up ground, or you're calling in your backup people that would otherwise be able to stay outside the room, and you're having to open that negative pressure room, there's other potential problems. And so I think there is a role for very careful positive pressure ventilation when it needs to be done. And it's better to be done with a lot of planning and carefully and making sure you have a good seal and that you have a filter in line. And I'm a big advocate for actually doing my mask ventilation with the ventilator. I think all of those things need to at least be considered, and we shouldn't say never.
Absolutely. And if you haven't had this conversation at your institution, for those who are listening, I will tell you that it's coming. Everyone has had this conversation, and Darren and Jared are exactly right. You want to try to avoid it, but if it's clinically necessary to better pre-oxygenate the patient, our guidance at our own institution is that you transition the patient using a tight-fitted, non-vented mask hooked directly to a closed-circuit ventilator, and that's how you pre-oxygenate them with positive pressure. I imagine at some point we might get to a place where a single limb unit has to be used. It would not be optimal, but if you think that you are safe using RSI on a patient whose SAT is in the low 80s, by the time those medications have been administered and the patient is in a place where they can actually be intubated, their SAT is already going to be in the 60s. And so if there's any hang up at all placing a tube and getting that patient reoxygenated, you are potentially going to be coding that patient, and that exposes everyone to much higher risk. With that, I'll pass it over to Adam, and I'm sure Adam has other things that he would like to comment on as well.
Thank you, Calvin. Hello, everybody. I'd just like to add to that last point that if positive pressure did need to be used, either in the context of waiting for neuromuscular blockade to maximally act, so in a minute or so after the administration of RSI medications, or after a failed first attempt because of the profound and rapid desaturation that might be anticipated or has happened, I would add in an oral airway just in order to minimize the needed insufflation pressures to achieve adequate ventilation. The second point I was going to address was the intubation in a negative pressure room. As Calvin alluded to, those are in some institutions in quite short supply. And as an anesthetist, we've been addressing whether or not we could convert our entire operating room suite into a negative pressure or at least negative flow environment. And while not negative pressure, we certainly were able to convert them into negative flow. Then you have to balance that against what that might due to surgical site infections. And I don't think there's any good data on that. But regardless, I do think the point is that if negative pressure, negative flow environments are not available, then you just have to do your thing in a regular room using appropriate personnel precautions of the appropriate airborne level PPE in the COVID suspected or positive patient.
Yeah, that's a terrific point. I will say that last week we had patients literally lined up to be intubated in one of our hospitals where we have one negative pressure room. And while we were lucky enough that we felt those patients could actually wait a brief period of time, and it turned out everything was fine, it's hard to operationalize that, and it's not optimal to intubate someone in a negative pressure room. But you're right, you just have to have bulletproof PPE. All your technique has to be pristine, and you have to think about all of these elements to prevent aerosolization of highly infectious viral droplets. A couple of other things that have. Oh, sorry. Go ahead.
Add one thing, and this might be obvious to everybody, but we do all of these things: intubate patients awake, high flow, BiPAP for the flu, which is pretty infectious. And so, what makes this any different? Well, the reason this is different is because flu is really a droplet disease, and the R naught for that, I think, is 1. So for every one person that has it, they'll give it to one person, and it's easier to contain. The R naught for this coronavirus is between 2 and 4, and the reason is because it's an aerosolized virus. So that's why this is so much higher risk than intubating highly infectious flu patients. That might be obvious to everybody. I just wanted to put that out there.
Thank you. Great point. Just to go down a couple of these other bullets, I think we've touched on some of these things. We at our institution we've made recommendations about neuromuscular blocking agent dosing, and we have, of course, everyone knows the range of dosing that is out there for rocuronium and for succinylcholine, and we have given our folks guidance that because we're estimating weights, and we often underestimate people's weights, and we want to avoid the scenario where someone could potentially respond to laryngoscopy, gag, cough, that we are telling our folks to err on using a higher dose neuromuscular blocking agent. And what that means for us in the guidance we've given is 1.5 milligrams per kilo of rocuronium and 2 milligrams per kilo of succinylcholine. I'm interested to hear what the other panelists think about this, all in an effort to make sure that the patient's optimally prepared as quickly as possible without the opportunity for a patient reaction during laryngoscopy. That has come up at our institution. It may have come up at yours, but I'm interested to hear what the other panelists think. Maybe start with Darren this time.
On the EMS side, we've been working with those doses for quite some time. So that's really not a change for us. And at my institution, that's not uncommon dosing already.
Great. Jared, Adam, anything to add?
Calvin, could not agree more. Go big or stay home with us.
Right.
So I totally agree with those doses.
Yeah, I agree. Locally, we are chronic underdosers of rocuronium, and we get away with it because we use VL predominantly, and we end up using 2 vials because it's just pragmatic. But we are really recommending go big with rocuronium in this case.
Excellent. And then one other thing that has come up, and we've decided to adopt this. Our anesthesia department is doing this also. I mean, it is habit for all of us to confirm tube placement with. Some of us are using quantitative, but some still use qualitative end-tidal CO2 detection. And what we have told our faculty is that it's fine to still do that. However, and anesthesia is given similar guidance, if you are intubating a patient using VL, and we'll talk about that in a minute because these folks should be intubated using VL and indirectly on the screen. And it's a straightforward laryngoscopy with a good view, and you and everyone else in the room who saw the tube traverse the cords are 99% sure it's in the right spot. That is there a reason why you couldn't just hook the patient up to the ventilator, especially if there's inline CO2 detection already in place? And do you need to go through the standard steps of first spot checking the location of the tube before you hook them up to a ventilator? And we have said, look, if you're pretty sure, you can skip that step, and it's reasonably safe given the circumstances. So that's an additional modification that will limit disconnects. And we're advocating that here, and I pitched that to the panelists to see if they have any other thoughts or if they're doing that at their institutions. Jared?
I don't really have thoughts about that. We haven't talked about it either.
Got it.
Adam here. Of course, in my operating room environment, I pre-oxygenate with the circuit, and after intubation, we put them back on the circuit, so the question doesn't usually arise. Maybe I could add one more thing to the spot check thing. When you're passing the tube, where auscultation might be difficult afterwards, it's probably also worthwhile deliberately placing the tube under the indirect visualization that you referred to, Kelvin, until the tube's cuff has just disappeared beneath the cords. That will minimize the possibility of an endobronchial intubation and decrease the necessity of auscultating afterwards. And it can be difficult when you're in full airborne level PPE to auscultate the chest, and probably a good idea to avoid contaminating stethoscopes unnecessarily.
That's a great point, especially if you're using a hood or some other containment device, which we'll talk about in a little bit. It's just technically harder to get to the patient's chest, and that's a great point, because if you pass the tube too deeply, then the tube has to be repositioned, and anytime you have to manipulate the tube, there's risk there.
And Calvin, can I just jump in real quick?
Of course.
The other piece of this, so again, similar to what Adam's talking about, I think outside the OR, we need to be better about using the ventilator to do our mass ventilation if mass ventilation is required, and then going directly, as you're saying, to the ventilator circuit. In general, I think that's a good practice. But the other piece of this is your capnography. I think there's folks still out there using the colorimetric capnography, and they're putting that in the circuit, confirming the tube, then taking that out of the circuit and putting in the continuous inline. And I think we've all advocated for a while, but it's worth making the point. We should be using continuous waveform capnography from the very beginning. We should use it if we're doing any mass ventilation, but that should be in the circuit from the get-go. And that's one more opportunity to minimize breaks in the circuit.
Completely agree. Terrific point. All right, well, let's move on. I think we've already done the roundtable. Let's see. I think here what I'd like to do is not take too long, but let's just see if there's any questions that are out there that we might be able to tackle quickly. And excuse my movement of the mouse here on the screen, everybody. And let's see if there's anything here. Well, let's tackle one topic that I think is going to come up. It has already come up, but will likely come up as we go further on in the presentation, and that is the use of apneic oxygenation. And that'll come up again in the next segment. But I already see a couple of questions about that. So I'm going to start off by just pitching that to the panelists. I have my own thoughts about this. We've discussed this ad nauseum amongst the EM group and with folks in the hospital. But Darren, the University of New Mexico, and you intubate these patients. Are you advocating for APOX? Are you not? If you are, is there a flow rate that you are advocating for? Or are you just avoiding it altogether?
I think there's still a fair amount of variability in that practice, and we haven't made a specific firm recommendation on that like we have about other things. I do think that we have on the emergency medicine EMS side of things, we just kind of go big or go home, and we went 15 liters for everybody. And I think there is most of the literature has been on much lower flow rates, and I think there is some concern that if you're blowing oxygen into the nose, that's circulating through the pharynx, and some of that's going to come out the mouth, and it may not be specifically coming from deep within the lungs, but does that add to some potential risk even in a paralyzed patient? I don't think we know the answer to that, but my personal practice is to go to continue to do apneic oxygenation, keep things as consistent as we normally do, but to go with lower flow rates and try to keep it more around the 5-liter range. But I can't tell you there's great evidence for that.
Yeah, we had the same debate. Ultimately, at our institution, in our guidance, we decided in the end to not promote that. And again, you're right. It's a little bit of we don't know what the right answer is, but enough people had an immediate allergic response to that idea that we basically kept it out. People started to ask about, well, what if you just used, like you had alluded to, different flow rates? What if we just used 5 and not 15? Is that relevant? Would that be helpful? And our final decision was that low flow APOX in someone who's really sick is probably clinically irrelevant, and high flow again might contribute to aerosols. But you are right, we don't know the answer, but that's what we decided at our institution. How about Adam or Jared?
Same for us. I mean, the efficacy of apneic oxygenation goes down the worse your shunt fraction gets. These patients have bad ARDS, and trickling in a little bit of oxygen probably isn't going to work at all and may cause aerosolization, as you guys both mentioned. So for that reason, we're taking the conservative route and not doing it.
Very similar. We talked about it at a low flow rate, 5 liters per minute. I don't know if that would have any effect even without a significant shunt fraction. To Jared's point, I'm sure it's got even less efficacy with a significant shunt fraction. And, as far as intubating patients in our ICU environment, that would require taking an oxygen tank into the room just because of limited oxygen outlets on the wall, which would increase the complexity of the entire thing. And it's already difficult enough in full airborne level PPE, and there's enough emotion and brouhaha surrounding intubating one of these COVID positive patients in respiratory failure that we just thought we should avoid the complexity that would introduce.
Great. All right. Well, what I'm going to do, I know there are other questions out there. We're going to try to get to them at the end, but we want to get through the entire presentation, so I'm going to move on at this point to the next principle, which is maximize first attempt success. And what you're going to see on here are things that are not new, but might be slightly different than what you're used to doing, especially if you're in a teaching environment. So some of the important concepts we thought of around maximizing first attempt success, you can see are listed here. First, and this is even without COVID intubations, the use of an airway checklist is helpful in addition to closed loop communication. And this is really critical, especially if you're dealing with a lean team in the room and multiple, two additional people are going to be responsible for multiple things, and we have to be on the same page. If you're about to do something, you need to tell people what you're about to do or what your second or third step is going to be if X, Y, or Z happens, and make sure that they verbalize that back to you. So there is a verbal, read back or speak back, so you know that they have not misconstrued your next actions. The second bullet point is something that continues to be an area of great debate at our institution, which is who should intubate these patients in the context of a teaching facility. And what we have settled on, clearly you want this to be an experienced clinician, an experienced intubator. This is not a learning case. This is not an intern, hey, let's show you how to hold a video laryngoscope type of intubation. This should be someone who has done hundreds of these and feels completely comfortable intubating indirectly on a screen. And is that the attending only? Is that a senior resident? Is it either? Who should that be? I'll tell you where we settled, and then we'll get input from the other panelists. I think video laryngoscopies, I think we can all agree that is the modality in which you should be intubating. That's the device to use. And whether or not you believe that makes you individually much more successful at placing the tube on first attempt, the additional advantage of it is that you can keep your face away from the patient because you can intubate on the screen. So if you grew up being a close intubator, this is an opportunity to be at a distance intubator. And video laryngoscopy allows you to do that. Of course, like any procedure, you want to have yourself set up for success. So have all of the necessary equipment at the bedside. If you're working under a hood, you want to have at least the immediately required equipment under the hood and in easy reach. Robust pre-oxygenation, we'll talk about that. This is probably going to be the point of greatest discussion. How do you do that? We have a very generic bullet point here, but we'll talk more about that in just a second. But clearly, you want to have the patient upright if possible, or in reverse Trendelenburg. Open up the FRC, put the patient on high flow, 100% oxygen, and if you're used to doing it for 2 or 3 minutes, give it a couple extra minutes if the situation allows. Just robust pre-oxygenation, as good as you can do. If you get into a place where a rescue maneuver is required and you're contemplating reoxygenating the patient either with a bag in an inline HEPA filter or through another device like a supraglottic airway, one thing to consider if the device is available, and it should be, you'd have that under the hood and immediately available, is early placement of a supraglottic airway as opposed to applying a mask and reoxygenating with bag mask ventilation. And the advantage is that if you have an inflatable supraglottic device, you can inflate it, you can manipulate that inflation and ensure that there is appropriate seal and contact, and then you can attach it to a closed loop ventilator so you don't have to apply positive pressure with a bag. And then the other is having a second clinician immediately available outside the room. If it's a very high risk, you might want to have that person donned and in the room with you, not at the bedside, but 6 feet away, so that if they needed to step up to the plate and be there in a second, they can be there without having to open a door and have aerosols escape into the main part of the ED or whatever environment you're in. So there are some other things that will come up, and we can talk about those. The bullet points are listed here, but these are sort of generic recommendations. Not generic. I mean, we thought about these, but if you have not instilled these things, you should really think about it. I think the 2 points of conversation we may want to tackle first are what does it mean by the experienced clinician, and then what's the best way to optimally pre-oxygenate your patient. With regard to who intubates, I'll just tell you at our institution, trying to juggle the educational requirements for our residents, but also making sure that the person who's intubating is very experienced. We have decided that it's the attending or the senior resident at the attending's discretion. That way, if you put some language in there in some guidelines that you produce that says the best intubator should intubate, and you have 3 people outside the room who are all pointing at themselves as the best intubator, you avoid that level of friction. The attending is still in charge, and we've decided that the attending is mostly going to do these, but can delegate it to a senior resident if they feel that that's appropriate. On that particular topic, I'm going to bump it around the room and see what the others think about that. How about Adam? Let's start with Adam first.
Thanks, Calvin. Interestingly, we had that conversation yesterday, and we landed in the same place, and that is that we can't or shouldn't preclude especially senior anesthesia residents from intubating these patients, so that we will allow that. I think the principle is a sound one of having the most experienced clinician intubate. Anecdotally, a study that has always tickled me was a fairly large-scale study in the anesthesia literature looking at risk factors for failed first attempt placement using video laryngoscopy. One of the risk factors was an attending anesthesiologist as opposed to a resident or a CRNA. So, I think I'm happy with the decision that we've landed on to allow at least senior anesthesiology residents to be involved in these cases.
Great. And I think, if you work at an academic institution, everyone on their roster has an attending who works clinically once or twice a month because they are mostly researchers. They have large grants. They rarely walk into the ED. But with staffing shortages, you are going to be calling everyone you have to step up to the plate and see patients. And that is, you have to think about that. You have to think about having the tough conversations with folks who are not in the clinical environment and basically trying to have your best athlete, excuse the athletic analogy, but you have to have your best athlete, your best batter at the plate. And how do you juggle getting everyone involved, but making sure the right people are doing the right thing and not having the wrong people trying to take care of a sick person or do an intubation if they haven't intubated in months or years, especially if they're used to overseeing trainees. Darren, Jared, what are you doing at your institutions with this?
This is Darren. We're doing the same thing. I think it's not like this is going to be over on July 1, and we have our residents are going to be out there, and they're going to be thrown to some crazy environments in this current world. So absolutely, same thoughts.
Same for us too. There's an interesting wrinkle in that some of the senior house staff feel like they're being thrust into doing something they may not be comfortable with. So my personal practice is that I'm just going to be the default person to do it unless they tell me that they really want to do it.
Okay, so it sounds like we have general consensus about the experience level and exclusion of certain types of people for intubating. And I think, again, people who are listening, if you haven't had these conversations yet, if you're in a place where this has not blown up, these are the conversations that you will have, and I think it's helpful to hear what other people are doing who have already been through these motions. Video we've already talked about, so I won't belabor that. Please use video. Optimal pre-ops, let's tackle that because this comes up often, and I don't know if anyone knows what the right answer is. I think you have to juggle the risk of aerosolization with robust pre-oxygenation so that the patient doesn't desat so quickly that you actually have time, even if you're good, even if laryngoscopy is easy, even if it goes in on the first try, that the patient doesn't critically desat and have some cardiac adverse event in the setting of the sat dropping to 40, even if you're fast. Now, everyone has heard stories of patients who have been intubated whose sats are reasonable when drugs are given, and they desaturate so quickly that people are scrambling to get the tube in, and even when they're fast, people are having problems. So what's the best way to do that? And again, I don't know if anyone knows the right strategy. At our institution, we have settled on sort of a two-pronged approach. And I think the patients fall into two buckets, right? There are the patients who are moderately ill but have a concerning trajectory, and they don't have a critical oxygen requirement yet, and you're intubating them under the early tracheal intubation guidance. And for those folks, we sit them up, we put them on a non-rebreather with as closely approximated mask as possible at 15 liters. We are not advocating initially for higher flow rates, and everyone has heard about flush flow rate oxygen, and we're staying away from that for now unless there's no other option because of aerosols. And if someone is not adequately pre-oxygenated on face mask oxygen upright on 15 liters, then we, if the equipment's available, we are moving them to the method that we've already described, which is closed circuit positive pressure ventilation with a non-vented mask hooked right to the ventilator, which should be in the room anyway because you've called for it because you're going to intubate the patient. And that's sort of our main strategy. And then for the folks who are clearly sicker, we are calling for RT early and putting them basically right on closed circuit positive pressure ventilation by tight fitted mask right off the bat. You may have to stand at the bedside to hold the mask in place to make sure that there's adequate seal. Some of these things are attached and held in place by straps and Velcro type devices, but these things slide around on the face. The patient may be agitated and moving around, breathing very quickly, so you may have to actually stand there and hold the mask on to get a good seal. But that's what we're doing at our institution. I'll bump it around the room and see what other people are doing, and I'm sure there'll be questions about that, which we'll tackle at the end of this section. So how about we start with Darren?
I agree it's good to kind of stratify those two groups of patients. And I think it's that second group that's particularly challenging. But in line with what I was saying earlier, I think that it's better to do what you need to do carefully early to give yourself and the patient some reserve and some time than to be in the hole later and be scrambling frantically or calling in people that you didn't need to call into the room. So I don't personally think that using CPAP to pre-oxygenate a patient is out of the question. I think it needs to be done thoughtfully with filters in a filtered system and, ideally just doing that off the ventilator. But I think the more we try to deviate from what we would normally do for a really sick patient like that, the more likely we are to get into trouble.
Yep, and then I'm going to pass it over to Jared and then to Adam. But the one thing I would just say is, and again, this is going to come up. We have had at the bedside respiratory therapy and other folks say to us when we have mentioned, look, this person's super sick and we need to do CPAP to better oxygenate. And the response has been, we are not doing positive pressure ventilation on any of these potential COVID patients for any reason, period. And, and that's mostly a communication thing and explaining to them why this has to happen. And of course, getting buy-in from respiratory therapy leadership, ICU leadership, anesthesia leadership, so that, when respiratory therapy makes their way around through all of these different departments and they hear very different things, it is super confusing for them. And RTs are on the front line more than we are. They are in the room with these patients all the time. They are very nervous, as they should be, and we need to do a good job at explaining what we're doing, but also listening to their concerns and trying to find the right middle ground between doing what's right for the patient and doing what's safe for everybody. How about Jared?
Yeah, we're in the same boat as both of you.
Great, Adam. Anything different or anything else to add? How are you dealing with this in Halifax if it's come up?
Well, as a sole anesthetist on the call, I mean, as far as the operating room environment, obviously we're not routinely intubating COVID patients in the operating room for their respiratory failure. But the at-risk or COVID positive patient who happens to be coming for an emergency operation, we would probably just be pre-oxygenating with the regular circuit while the patient breathes spontaneously, well-fitting face mask, maybe additional closey adjustable pressure limit valve to give a small amount of CPAP. As far as intubation outside of the operating room, very much what you've said already. Non-rebreather to 15 liters, ideally using a type of non-rebreather that might have filters, so the Tavish mask or a high-ox with an expiratory filter on it in order to limit viral shedding as the patient expires. If that's inadequate, then move to CPAP, probably starting at 10 centimeters of water in order to see if the patient could be better pre-oxygenated. So that's outside of the operating room.
Great. Yeah, so it sounds like we're all generally in the same ballpark with this. Let me get the other panelists' thoughts on rescue bagging versus early supraglottic airway placement. Should that need to happen? When I ask 10 people, 5 are on one side of this and 5 are on the other. And I think that's going to be the case. I see the advantage of early supraglottic airway placement because you can attach the patient right to a ventilator. But other folks are concerned about how complicated that might be. And the first thing people are going to reflexively grab for is a bag. And maybe if you do that with two-handed mask hold, oral airway, ensuring tight seal, that maybe that's the right thing to do. So, Darren, this may be more in, this may be right in your wheelhouse, because I think EMS providers, if they feel like they have to intubate these patients in the field, and I don't know if they're doing that routinely or not, but this may come up often for them. So what are your thoughts on that?
Well, and I do think there is the EMS side of this, which hopefully we can get a little bit to. I think in general, back to consistent theme, the more you deviate from standard practice in critical situations, the more likely you are to have trouble. I'm in general a huge advocate of supraglottic devices, and I think in general on the EMS side, I think this is a particularly timely. What I've instructed my EMS folks that have to have the opportunity to intubate, and this is mostly, I'm not talking about interfacility critical care transport, this is like cardiac arrest care, which is a huge debate right now in the EMS world, is stop CPR during your airway, and you still have one opportunity to intubate, or you can go straight to the supraglottic. It's a trade-off. There's a little more risk long-term of some leakage around a supraglottic versus the short-term risk of being more in the airway to do an intubation. And I think there's a individual risk-benefit that people are going to have to look at. For the hospital side, what we've talked about at our institution is if you just think you need one more attempt, it would be great to get an ET tube in and really simplify things and close the circuit for these patients. Then careful mask ventilation is reasonable. If you just saw a really swollen, messy airway, then by all means have that supraglottic there and just put it in right away. And I'm a big advocate then for intubating through that device endoscopically with a closed circuit and continuous ventilation.
So I think that's a great point that you bring up. There probably are two different variations of this. There's the person where you feel like you're very close. If you just had one more quick attempt, you know what limited you on that first attempt, and if you could just adjust a little bit, you're convinced you'll get it on the second attempt. And you're right, you should be allowed to do that because that's the best thing. And then there's the patient where they desatted so quickly, you weren't even close to the airway, you're not really sure what's going on, and you have to think about what your options are because laryngoscopy may not solve this particular patient's problem. Then placement of a supraglottic airway allows you the time to think about options, and then, of course, a conduit to the airway that you might be able to intubate through. So that's a great way to think about that. How about Jared or Adam?
Adam here. I 100% agree with that. I don't think that I could quote you a compelling study to suggest that well-performed face mask ventilation with a two-handed so-called VE grip and an oral airway is any less likely to cause a leak with positive pressure than a supraglottic airway. We have to remember that outside of the anesthesia environment, many practitioners don't routinely use supraglottic airways. So a blanket recommendation that you have to place a supraglottic airway after a failed first attempt at intubation, that might not necessarily result in a leak-free environment with positive pressure. So I totally agree. After failed first attempt, if you needed to go to positive pressure, I personally would be putting an oral airway in, two-handed face mask ventilation, going to the second attempt. If for whatever reason the second attempt failed with my go-to device, then I would probably be putting down an intubating type supraglottic airway of second generation design.
Excellent. I like that. I think that's a great way to think about it. Jared, what were you going to say?
No, I 100% agree with everything you guys are saying. I actually think that it's pretty nuanced because a lot of the time you're going to stop your first attempt because of desaturation, and now you have to oxygenate that back up. But it also depends on the degree of anatomic difficulty they have. And so, like you mentioned, you may need to use it as a conduit for the airway. But pragmatically, there are problems with both options, right? So if you have a drape on, hood, box, whatever you want to use, and you think your backup plan is going to be mask ventilation, bag valve mask ventilation, and for years we've been advocating this two-person, two-handed Thenar grip. Well, you can't do that very easily, especially if you're using that box. And then if you're going to use a supraglottic airway, you have to have it there under your hood or in your box for when you need it. And you're going to have to throw all that stuff away as soon as that intubation's over. So if you didn't use it, you have a perfectly good supraglottic airway that's sterile that now is contaminated, you got to throw away. So there is some nuance here to it, and I don't know that there's clearly a right answer, but all things being equal, I agree 100% with what you guys are saying.
Excellent. All right. Well, because we want to make sure we make it to the end and we want to talk about the EMS stuff and get to some questions, let's move on. We've done the around the table. I'm going to save the rest of the questions to the question and answer section at the end. So please keep submitting your questions, and we will try to get to some of the themed questions at the end. And let's talk about the last principle, which is limiting contamination. I think this is going to be a little bit of a quicker discussion because I think we all know what the general principles are here. But, of course, you want to limit your own contamination. And so this is a time where, and this is not unique to emergency medicine, of course. This is all medical providers. We want to help. We want to help people who are sick and who are in trouble. But I think this is a time you have to not be the hero necessarily. And what I mean by that is if you have someone who's a COVID patient or highly likely to be a COVID patient who's in respiratory distress and they've just been placed into a closed door room, and you realize that that person needs help right away, you still have to protect yourself. This is not a time to run in with your mask off or your, without a face shield or a gown or other things that would be standard PPE. Take a minute or two and put on the PPE correctly before you walk in that room, because it does no one any good to run in there a minute or two early and then it turns out, 6 days later you have fever and respiratory distress and now you're in trouble just like the patient. So I respect everyone who wants to rush right in and help people, but it's also a time to take a step back and make sure that you have all the appropriate enhanced respiratory PPE on. We are using a double glove technique, and the reason why that's important is because some of the equipment that's going to be at the bedside that has to be reused, like the VL stand, you hope would not be completely contaminated, but some things are going to have to be wiped down. And then as you doff your equipment, your PPE, always with a monitor, ensuring that you've done it the correct way. Having a second set of gloves on is critically important so that you have a clean set underneath for the final stages of your doffing. If you can, we recommend limiting the in-the-room team to 3 people, because prior SARS experience has proven that one of the risk factors for cross-contamination is having more than 3 people in the room. And what made sense to us is having one primary nurse, a respiratory therapist, and the intubator. What has happened in reality at our institution is that it's a 4-person team, for better or for worse. And the reason is that unless the attending is doing the intubation, and even if it is the attending, oftentimes we want the senior resident in there with us, but our senior residents have strongly preferred to have the attending in the room. Now, if people are in the room there to help, we recommend that they're not right up against the edge of the bed, that they can be in the room ready to assist as needed, but should be 6 feet away at the end of the bed, way up by the proximal wall against the edges, to try to stay off the immediate aerosolizing field as much as possible. We will talk about quickly different varieties of drapes and hoods and boxes. If you haven't seen a YouTube video on a drape or a hood, then you've just been living under a rock. So there's lots of these things that are out there, and we are moving towards, at some point, probably in the next few days, a reusable, the frame is reusable, but the drape is single use, intubation hood that slips over the patient's head, and you cut slits in it for your hands, and you operate within this hood that has been modified to have suction attached to it, so you try to create a negative pressure environment inside the hood. That's another way that you can limit cross-contamination in the room. And then the other stuff is very common sense about how you take soiled equipment, throw it in a double sealed biohazard bag. And then the most important thing, because you may be thinking about the intubation that took place, you may not be focusing on your doffing technique, but as you finish the procedure, it is really important that as you take this PPE off, that someone is watching you with a checklist to ensure that you are taking your time and doing it correctly. With hand hygiene, which we know is interposed in a lot of these steps at multiple spots as you doff. So that's important to do that correctly, safely, and slowly as you finish the procedure. I'm going to pass it along to the other panelists and bring up a few other things that I've already sort of touched on for any other comments around the table, starting with Adam.
Calvin, again, very much in line with what you said. For our airway team, we also landed on the intubator, who's a staff anesthesiologist for the roving around the hospital team, an RN and an RT, and the fourth individual is the anesthesia resident who stays outside of the room but is in full airborne level PPE to act as the runner and to act as a second resource to come into the room should difficulty be encountered or for any other reason. Communication, of course, between inside and outside the room then becomes an issue. If there's a window, of course, you can wave the person in. But if you happen to be intubating in a room where there's no window, then we've added walkie-talkies or a baby monitor, one inside and one outside, so the communication can continue. And to your last point, Calvin, well known, of course, that doffing of the PPE is a high-risk time for contamination. So great care to do that according to a checklist or a coach, I think, is very important.
Great. Yeah, completely agree. It's a high-risk time, and you don't want to bring this stuff outside the room. How about Jared? Anything to add?
100% agree with everything you both have said. However, I want to add one more thing to bring this full circle. And this is another reason why to intubate early, because this process takes a lot longer than you think. It takes about an hour from start to finish by the time you get everything ready, get donned, go through your checklist, make sure everyone's set, have a plan, go in there, intubate, and then doff. That takes an hour.
Yeah, it's a very slow process. Darren, anything to add here?
Nope.
Okay, then let's move on. So there's a last couple of things we want to touch on, and then we'll get to the questions. So we've done this. Darren, EMS providers are frontline personnel. They are taking care of these patients and transporting them in austere conditions. They obviously don't have the luxury of negative pressure environments. And I think there are a number of special considerations that you wanted to touch on. So I'm going to pass it over to you and let you go through this slide.
I appreciate that. And, clearly much of what we've talked about is applicable in the pre-hospital setting. And really in pre-hospital, we're talking about two distinct areas. We're talking about emergency field response 911 scenarios, and then we're talking about interfacility transport. And either way, you end up in a small confined space that's poorly ventilated with a patient, and that is just an infinitely greater risk over time than being in most of the hospital settings. We're dealing with some of the same issues. I think we're trying to limit providers that are in the back of an ambulance. In an aircraft, usually we have a limited number anyway. I think this idea of avoiding nebulization and CPAP, I think is even more applicable in that environment, especially because we may not have, for example, everybody may not have a CPAP device that can be filtered. And So clearly that is a game changer. So it depends on, to some extent, the technology and you have and what's available. But I think in general, on the 911 side, we're just trying to get people to the hospital with a minimum of exposure and interventions. And then on the interfacility side, it's a bit more complicated. I did mention earlier, I think there's reasons to want to stop CPR during, any time we're opening the mouth. I think pressing on the chest just seems like that's going to express aerosolized material, and that goes against all of our prescriptions in general to minimize interruptions of CPR. We are also changing guidelines on which patients we attempt resuscitation for, to make sure we're focusing on patients that are probably have an unrelated cardiac arrest and have a reasonable chance of a good outcome, and certainly not trying to do heroic resuscitations on patients with advanced COVID disease. And so that's also been a big game changer for us. The EMS has, in general, on the 911 side, really moved in most places to extraglottic devices for cardiac arrest. So I think that, in general, is a good thing. We do wonder if, since these devices don't completely seal the airway, is there a chance of some aerosolizing around that? I don't think we entirely know the answer. In most cases, we're not using ventilators that are measuring, delivered and returned volumes, for example. So people are trying to make more effort to close the mouth. There's been thought of whether you should be packing something in the mouth around this. I don't think there's any science to that. But that's, these are the challenges. I think the best thing for EMS is just not to be resuscitating patients who are high risk, if we can justify that. And along the same lines, I think in the pre-hospital setting, if you do have RSI available to you, I think you should be very judicious, and if at all possible, that should be put off to arrival at the hospital, just because of the complexity and all the issues that we've been talking about during the rest of this discussion. I think where this has really come up for us is the issue of interfacility transports, and does every COVID positive patient need to be intubated because you're going to be in a very tight enclosed space with somebody, and there are patients who just really have a reason to be at an advanced facility because they're at a very small rural facility that really doesn't have the capability to take care of them, but really doesn't meet anybody's criteria for intubation. And that is a real challenge. And I don't think anybody has right now the right answer for that. I don't think that, CPAP or something with a filtered system and a tight mask fit and then everybody in N95s is out of the question. But how often do you have patients that at some point feel claustrophobic in an aircraft and just want to take that mask off? And that's a lot of risk for everybody there, especially because you really can't use something like a PAPR in a helicopter and wear a helmet and a headset. So we're trying to intubate people if at all possible. We're having very specific case-by-case discussions if that's not the case, and utilizing other platforms, ground and fixed wing when available. But EMS is really, as you said, on the front lines and in a really challenging place, and this is definitely changing our general practice patterns.
Great. No, that is, I'm glad that you brought all this up, because I know we have EMS providers who come into Airway World and are listening to this presentation. I think this is high yield information for them, and I'm sure there'll be some questions at the end that we will touch on. So just a couple of additional. So thank you, Darren. A couple additional quick things before we get to the questions. I thought of some common conundrums that have come up in the clinical setting in the ED and probably in other places as well, and I just wanted to touch on them quickly. I think we already discussed this, but what should be the institutional or departmental approach to patients who come in who are dyspneic and it is for example, a very low risk infection story? And what has come up to me now 3 times is the following scenario. An 80-year-old who was previously fine 45 minutes ago and then had rapid onset of shortness of breath. They call EMS. The patient's pressure is 200 over 120, and it's very clear that they flashed. And they were fine before. There was no fever. There was no infectious symptoms. And, the standard treatment for this person would be nitrates, BiPAP, etc. And what happens when someone says we're not doing positive pressure ventilation on anyone who's short of breath because there is always a chance that COVID is there, and that's going to come up. And my suggestion to you would be to get the stakeholders involved in a short discussion to come to some common ground approach. And what we have decided on at our institution is that at the EM attending's discretion, if the patient has a very low risk story for an infectious cause of shortness of breath, that we will request BiPAP if that's the right therapy. We will have a quick discussion with RT explaining the scenario so that they feel comfortable that in agreement that it's a low risk story. And then we will do BiPAP, but we will do it in a negative pressure room, and people will wear full respiratory precaution PPE. And that was sort of the middle ground where we settled on our approach, because it's not the right thing to intubate everybody who is in need of oxygenation ventilation support. And I worry a little bit about non-COVID patients getting some pretty unfortunate care if you take that type of approach. For intubations, unless it's a super clear story that the person is having a non-infectious related need to be intubated, like anaphylaxis, we are, because the story is often not clear or incomplete or the patient's not awake, we are doing all intubations with very rare exception as if the patient had COVID. And this has come up on the floor actually with patients who were intubated and people were not wearing PPE, and then the day after they were intubated they spiked a fever, and then it became a big hot mess. Alignment of intubation guidelines, I strongly encourage this. There's a tendency for departments to work in silos because everyone's trying to get something out to their providers quickly. But to the extent that you can get RT, anesthesia, critical care, other stakeholders together in a room to share guidelines and make sure that the general approach is not contradictory, that will save a lot of follow-up work on the back end. And then I think Darren already touched on disaster standards of care, and we can talk about this if there's a particular question, but there's one thing I want to get to quickly before we get to the questions, and that's HEPA filter adaptability. And what does that mean? And this came up at our institution, and I just encourage you all to take a close look at your HEPA filters and understand the attachments, because we had a near disaster in our institution recently because the HEPA filter that was provided to us by respiratory is in this picture, and it's in line between the mask and the right angle part of the bag, and everything looks great, right? There's no sweat, no problem. And yes, if this is the configuration you have, there is no problem. But let's say you're in the unfortunate situation where the patient had to be tubed urgently, and there's some delay in getting the patient on a vent, and the patient's sat is very low, and you have to give them a breath with something. And so you're going to try to do it with the bag because you'll do what you have to do. And our ET tubes do not connect to our HEPA filters without two additional inline adapters. So the top blue one is a 22 millimeter adapter, and the clear one below that is a 17 millimeter adapter, and only with those two in place can you actually attach it to an ET tube. Now, if you happen to have what probably most of you have, which is a HEPA filter that has a dual lumen adaptability on the bottom end, then there shouldn't be a problem. But you don't want to get surprised by this. So this is another model that's in our institution, but is in short supply and has the advantage of attaching both to the mask and the ET tube without the requirement of additional adapters. So it may not be an issue, but I encourage you to take 5 minutes to look at your HEPA filters, because you may have guidelines that tell your providers just to hook up a HEPA filter, but most people do not know what that means. Have them send them pictures, encourage people to look at these things, put them in their hands, understand how they attach, and make sure that you don't end up with this situation. And if you have to have that, make sure the adapters are available. Here are some additional resources in case there's more reading that you want to do. There have been consensus guidelines put out by the Safe Airway Society and the Difficult Airway Society as well. A number of us wrote a paper, and that's available on JSEP Open. And there are lots of other good quality papers that are out there that you can read to get additional information. And so we have these for you to take a look at. And all of this is posted on the Airway site. .com, so you can have ready access to those if you visit our website. So in summary, there's lots of things in summary, but if I thought of 5, take-home points, it'd be the following. Number 1, protect yourself. We are a precious resource, and when we run out, there's no one else to take care of patients. Think about the 3 principles and maximizing your steps around those 3 principles. Collaborate with other departments early. We still have to care for people, so make sure that we're still providing quality, safe care. We can't run away from therapies because we're worried that they are infectious. You just have to do things carefully. And we will get through this if we work together, collaborate, and take reasonable precautions to keep ourselves safe. So while I'm pulling up the questions, if any of the panelists have any last thoughts before we start to tackle a handful of these, we won't have time to get to all of them. Of course, there's hundreds of people listening to this webinar, but I'm going to try to find some common themes and throw those out there.
Can I make one comment about the HEPA filters?
Yes, please.
So in our document, we recommended that you put a HEPA filter between the ET tube and the Y connector on the vent circuit. That I just want to clarify that recommendation is only for while they're in the emergency department. Most modern ventilators, maybe all modern ventilators, put a HEPA filter on the exhalation limb of the circuit. We recommended that one in between the two, specifically for in the emergency department, because there is a high risk of ventilator disconnect with all of the movement that goes on with patients in the emergency department and on their way to the ICU. Once they get settled, you have to remove that HEPA filter because the secretions will clog that thing up, and it will have to be replaced every couple of hours, which defeats the purpose of trying to not break the circuit.
Great. No, that's a good point. All right, so I'm gonna throw a few questions out there. Some of them are fast, some of them are not. So here's one from Eric, who asked, what pre-induction O2 sat in patients failing 6 liters per minute by nasal cannula are you aiming for? I can tell you what the SAT threshold is at 6 liters, which our inpatient team is using as a general trigger for intubation, and it's between 90 and 92%. I think if you're opting to oxygenate them pre-intubation, I think that you'd want the O2 sat much higher than that because you're already on the steep part of the desaturation curve. But in terms of identifying patients who will end up on the COVID intubation team high alert list, it's requiring 6 liters per minute by nasal cannula with a SAT of 90 to 92%. Jared, how about in the ICU? Is that, I mean, a lot of these folks get intubated in the ICU. Is that generally sound guidance?
Yeah, so you and I had this conversation a week or two ago, and if you had somebody who was breathing on 6 liters nasal cannula, the reason 6 liters is the cutoff is because that's what the highest flow through a regular low flow nasal cannula is rated for. And they're breathing 25 times a minute to maintain a saturation of 90 to 92%. Those are the people that you would escalate to a rescue therapy. And if you look at ARDS studies, they usually use that up to 10 liters with those same respiratory rate of 25, O2 sat at 90 to 92% to diagnose or meet inclusion criteria for hypoxemic respiratory failure. So those are the patients that you would escalate to a non-invasive therapy. We're not recommending that. So then you would intubate them, and to pre-oxygenate them, you should still be able with the non-rebreather to get them up. And if you can't, then the closed circuit positive pressure like we are discussing. Does that specifically answer the question, or?
I think so. I think so. Adam, Darren, any other thoughts or anything you want to add?
No, not for that one. Thanks.
Okay. I see a couple of questions about succinylcholine, and so I'm gonna lump these together. The two questions are you using sucks, and or is there a reason that succinylcholine should be contraindicated in these patients for a variety of reasons? One perhaps being that they might be hyperkalemic because they're critically ill. I mean, are you using sucks, and at what dose? I will tell you that ROC and sucks are drugs that are readily available. We do not give our providers necessarily any strong guidance for one versus the other. Our dosing is 1.5 milligrams per kilo for ROC, 2 for sucks. One other person asked, what about the added advantage of Shigamidex, and does that push you towards using a ROC over sucks? And I would say that in these patients who desaturate so quickly, that if ROC is on board and your rescue strategy is cross your fingers and I hope that the Shigamidex wakes them up, I think that's going to be problematic. And we would want people to follow standardized algorithmic approaches to the failed intubation attempt or a can intubate, can oxygenate situation. But we have not told people they couldn't use sucks, and that's the dosing that we recommend. But maybe other panelists have heard otherwise. Darren, how about you?
Well, we're similar. We're generally a rocuronium facility. Assuming you have plentiful supplies of both medications, I think either one at the right dose would be fine. I would agree these are not patients where if you're intubating them, waking them up is an option. So the Shigamidex really is off the table for me. I think the faster a drug works, if you're trying to minimize positive pressure, you could actually make a case that succinylcholine may have a minimal advantage. But for us, we're early in this. We're kind of at the inflection point. We're just really ramping up on our COVID intubations, unfortunately. But for now, our plan is still rocuronium.
Great. Adam or Jared?
Calvin, if I may, totally agree with what's been said so far. I would just add the other advantage to rocuronium is that if you do have a failed first attempt at tracheal intubation, it allows a smooth transition into a second or, heaven forbid, a third attempt without having to worry about redosing succinylcholine, which may have been wearing off at this point. I mean, these are very, very difficult and busy situations in full airborne PPE. You just want to minimize complexity if at all possible, and I think you get that out of rocuronium. But like you, Calvin, we don't prescribe one or the other to our providers in our Airway document. We have both present. I personally will be using rocuronium.
Great. No, it's a good point. I mean, you don't have to worry about someone starting to move and redose at a time where you really need them to be still, and so you can do your thing. So that's an excellent point. One person had mentioned, Ben, thank you for mentioning this, that please keep track of your internal neuromuscular blocker stores, because there are reports of places running out of rocuronium in particular. So just be aware, get check-ins. You don't want to be looking for rocuronium and find out at the bedside that it's not available. I mean, you could always use sucks, but if you weren't ready for that, it could be surprising.
Calvin, can I just comment to that?
Yes.
Most hospitals, as the pandemic hits, do stop doing fully elective surgery. So that on that basis, the consumption of rock uranium in an entire hospital should have dropped. So to the point of the individual who posed the comment, and it's a good one, we have certainly faced drug shortages, including of rock uranium in the past, so it's absolutely on the radar, but at least there will be less consumption in the operating room environment of that drug.
Excellent. Okay, we have, and I'm going to, well, I'm happy to give you my thoughts on this, but Darren, I'd be very interested in what you think about this. There's a question about if you had a choice between an iGel, the advantage, of course, is that it's rapid insertion, no need for inflation, or an inflatable supraglottic airway, which then you could adjust or overinflate even a smidge just to ensure there's good seal and less leak. Do you have a preference? Is it sort of dealer's choice, or is there should we really be favoring one over the other? I kind of like the idea of something that is fast and easy to insert, because I imagine that there's a scenario where reoxygenating the patient is its relatively urgent need. And I can see someone fumbling with a small syringe if they happen to grab a small syringe and having to, attach that 3 or 4 times to properly inflate an inflatable supraglottic airway. But what are your thoughts on that? Any strong feelings?
I don't. I think there are studies looking at the different leak pressures of all the different extraglottic devices, and the iGel does surprisingly well despite not having the inflatability. And sometimes the inflatability leads to people overinflating devices, thinking that that's going to, solve all the leak problems, and it doesn't work that way. So I think there's small potential differences between different devices. I think the most important thing is to know when to move to an extraglottic device and to use the device you're most familiar with. It is my preference to use a device that you can intubate through, so that you are not then having to go through a whole nother maneuver to exchange that device to an ET tube. That would be the most important factor for me. But I'm sure Adam has a lot of perspective on that as well.
Sure. In order, my 3 criteria would be: number 1, familiarity. So I think probably whichever device you're most familiar with. Second most important is that it supports endoscopic guided intubation, Darren, as you say. And then third most important criteria would be a 2nd generation design, meaning that it supports a higher seal pressure and has an esophageal drainage port. But honestly, familiarity, again, you don't want to step outside, if at all possible, your normal practices.
No, that's a great point. Do what you know how to do, and stick with that if it's reasonable to do it. Jared, what about you? Any additional thoughts?
No, I have nothing to add to that.
Okay. There are several questions, and I think I'll summarize them by asking the panel the following. And I don't think that we know, I'll just say I don't think we know the answer to this, but if you were to rate the possibility of aerosolizing virus, is there a difference between bagging a patient with good seal or placing a supraglottic airway that seems to be well seated, well positioned with proper inflation, provided that they both have HEPA filters in place? I mean, do we know the answer to that? I'm sure it boils down to technique, but I guess the point of the question is, should we be advocating for one over the other? And I think Adam may have already answered this, which is do what you know how to do and do it well. But do you have strong feelings, and this is open to anybody?
So Adam here, I do not think that one has any advantage over the other. I'm not aware of a study that has looked at that. That doesn't mean it doesn't exist. Yep, again, do what you're most confident in your hands. Yep, that's all.
Agreed.
Okay, I have a question along those same lines, actually a specific question for Dr. Law. Which supraglottic airway do you personally use as a conduit for a failed VL? Which I think is unusual, but if it happens, what do you use? What's your go-to?
Right now at our institution, we are using the LMA Evo.
Got it. Okay. Actually, follow-up question for you, because I want to make sure, I know that there's anesthesia providers out there, and I want to make sure we have some anesthesia questions also, and then I'll look for some critical care questions, and then we'll probably wrap it up. Question for Dr. Law. We are still doing electroconvulsive therapy under general anesthesia. These are traditionally masked cases. Do you recommend orally intubating these patients to avoid aerosols? We don't know if they are COVID positive.
Good question. I know it's a subject of contention. We are not intubating our ECTs right now. Obviously, we are looking at trying to avoid any procedures that don't absolutely have to be done. So that would be the high-level answer. But failing that, mask on the patient, put the patient off to sleep, pre-oxygenate, put the patient off to sleep, procedure mask over the patient in addition to the bite block. But we are not actually intubating them at present.
Got it. Okay, thank you. Here's a question about age and appropriateness of providers, and I actually see a few questions about this. Are any of you recommending any age limit or personal health conditions in the context of intubating or performing aerosolizing procedures on patients? I will tell you at our institution, there is a system level recommendation on this, and it runs through HR, and individual departments are welcome to micromanage this or manipulate this if you want. But we have two things. If you are a high risk person, either by age or immune suppression or something, we are modifying their clinical practice to put them in lower risk environments, and that could be the tent out front. It could be cool zones that may be set up in your department, or we take them off the clinical schedule completely, and we will worry about it later. That's what we're doing. That makes sense to me. Again, in the spirit of trying to not cross-contaminate, especially high-risk people. But I'll toss it out there. Are you folks doing the same thing? How are you approaching that?
I'll go first. It is an ongoing discussion for us. In the emergency department, we have recommended that the people with comorbidities or older faculty trade out of their shifts in the hot zones. In the ICU, we have tried to limit exposure to the COVID ICU, and that's more of a voluntary basis if people feel uncomfortable. I think we worry about them, but I'm sure they are very worried about something happening to us too, and so there's a lot of guilt going around both ways. I don't think there's an easy answer.
All right, and Jared, we were talking about this before the broadcast, so this is probably most appropriate to throw to you. What about proning someone who is satting low, like 70%? Can this save someone from getting intubated?
I would not do it to save intubation. And the reason is, well, I guess here's how I would approach it. If somebody's on a low flow nasal cannula and they are with it enough to voluntarily roll over and lay on their stomach, I think that is okay as long as they are maintaining normal oxygen saturations. When they start to become hypoxemic while they're on their stomach and prone, their risk of rapid desaturation leading to PEA arrest goes up substantially when they unprone. And so I would not, assuming that you have ventilators available, I would intubate those patients. And certainly if you're at a place where you're using high flow and you put them on high flow and they're on their stomach and they're satting in the 70s, that person really needs to be on a ventilator.
Got it. Perfect. Thank you. Anything else to add from Adam or Darren?
I just want to say that a lot of these decisions, as Jared just alluded to, will change once the supply of ventilators is threatened. So it's two almost very different scenarios. So that needs to be thought about.
No, it's a great point, and that's probably a good thing to mention about this entire presentation, which is we are talking about common sense, optimal approaches for folks when resources and equipment is available to do the things that we have recommended. But we're all going to be in a position, well, maybe not all of us, but I think most of us will be in a position where we have to bend these rules a little bit to continue to take care of folks. And that's happening in New York. I know it happened in Washington, and I think we're heading towards that in Boston.
Can I make one more comment about proning real quick before you move on?
Absolutely. Yep.
So proning should be the standard of care in ARDS if you're on a ventilator. I mean, it is one of only a few things that have been shown to reduce mortality. Our national practice pattern is to not prone because it is labor intensive, difficult, that kind of stuff. And so we just haven't adopted it as much as we should, although it should be standard of care. However, there is a significant risk of cardiovascular collapse on unproning patients. So I really worry about having patients on nasal cannulas or high flows, sat in the 70s, laying on their stomach, and what will happen to them when they unprone. That's all I wanted to say.
No, I mean, I think because this is very common, I'm hearing about proning patients awake, asleep all the time, that and this will not be something relevant for emergency medicine necessarily, but upstairs I think that's a really good warning to heed. All right. Well, look, I apologize. There's lots of questions there that we're not going to have time to get to. I want to respect everyone's time, not the least of which is the panelists' time and their involvement in this. I thank everyone who listened. I'm sorry if we couldn't get to everybody's questions. Please visit the airwaysite.com for the articles, and again, we'll send out instructions. You will receive a webinar certificate by email within 3 weeks. And just lastly, I want to thank everyone who joined us. Please be safe out there. We will make it through this, and hopefully it doesn't last as long as we fear.